Before we begin today as well, I want to recognize a few folks today. First of all, I'd like to recognize Shekinah Johnson. She's the wife of the late Arthur L. Johnson, who our lecture series is named for. So thank you, Shekinah, for being with us today. I'd also really like to thank the DTE Energy Foundation for their generous support of our lecture series, as well as a new sponsor, St. John Providence Health System. So again, thank you for your generous support. Finally, I'd like to thank the Algip Board for bringing this event together today, along with Joy Clark, our Associate Director of Engagement in the Alumni House, for their efforts in, again, making this possible. So thank you again. And without further ado, it's my pleasure to introduce Deputy President of Wayne State University, Dr. Phyllis Froome.
Good morning. Thank you, Ty. Well, I join our alumni president in saying welcome and good afternoon, everybody. Welcome to Wayne State University and to the Arthur L. Johnson Urban Perspectives Lecture Series. This series has been going strong for more than 20 years as a way of expressing the university's high regard for Dr. Arthur Johnson. The Alumni Association named this lecture series to honor him upon his retirement. Dr. Johnson, who left Wayne State as Senior Vice President for University Relations, was known for his civil rights activism, his passion for the arts, and his dedication to education. Throughout his career here, Arthur was a tireless advocate for the university. He also worked to change the face of Wayne State by strongly promoting the hiring of women and minorities. He touched thousands of people through his work with educational, cultural, and civil rights organizations, here and across the country. We are all better off for having had a man like Arthur Johnson among us. We're just talking about that. There will never be anyone like him. Through the years, the series has taken on topics serious, amusing, and everything in between. Today's program promises to be informative, in part because of our two speakers, Nancy Schlichting, President and CEO of Henry Ford Health System, and Joseph Mullany, CEO of the Detroit Medical Center. It also promises to be informative because of the subject. What are local health systems doing to ensure the health of people of Detroit? It's no secret that our city, like many urban settings, has an inordinate amount of citizens with inadequate health care programs. Simply put, many people in our city are doing without even the most basic health care. Nancy and Joe will be speaking on this topic and others today. They'll give some perspective to these growing concerns, as any good leaders would. But ultimately, it's our role as a society to become informed, as all of you are doing today, and then become engaged in change, as I hope many of you will do tomorrow. Again, welcome to our campus. I believe you will enjoy today's discussion. I know I will. And thanks for coming to the Arthur L. Johnson Urban Perspectives Lecture Series. Welcome.
All right. Before we get started, I have one more very important person to introduce. I'm going to do that today in the absence of the president being here, so let me get started with that. Our moderator, Loretta Davis, is with us today, and we thank her for joining us. Loretta has over 25 years of leadership and management experience in health and human services in both government and nonprofit environments. She has an extensive background addressing the complex health issues of the uninsured, underinsured, and vulnerable populations. Currently, Ms. Davis serves as the president and CEO of the Institute for Population Health, and she also leads a team of professionals committed to maximizing positive health conditions in populations and communities through collaboration, inclusiveness, scientific inquiry, and the application of proven health practices. Ms. Davis holds a Bachelor of Arts degree from the University of Michigan and a Master of Science in Health Administration from Central Michigan University. Thank you again for moderating for us today, Loretta.
Thank you. Thank you. It is such a pleasure for me to be here today, and I'm really excited to see that Nancy is as excited to speak as I am to hear her. But before she does that, it is my great honor to be able to introduce Nancy Schlichting. Nancy is the Chief Executive Officer of Henry Ford Health System, which is a nationally recognized $4 billion healthcare organization with 23,000 employees. She is credited with leading the health system through a dramatic financial turnaround and for award-winning patient safety, customer service, and diversity initiatives. She joined Henry Ford Health System in 1998 as Senior Vice President and Chief Administrative Officer. In 1999, she became its Executive Vice President and Chief Operating Officer. Then in 2001, she assumed an additional role, the role of President and Chief Executive Officer of Henry Ford Hospital, and she is credited with the financial turnaround. In June of 2003, she was named President and CEO of Henry Ford Health System. Please join me in a round of applause for Nancy.
Thank you, Loretta. And I am eager, and I was trying to avoid the introduction, I think, so that's all good. I am really honored to be here today, and the only really feeling of sadness is that Arthur isn't with us. And Shekinah, I recall I had the opportunity to speak here a few years ago when Arthur was with us, and it was just such a pleasure to have the privilege of getting to know him and spending time with him. And I think we all miss him, but I know his presence is here today, and it certainly continues to inspire all of us who are working in the community and certainly working on behalf of the citizens of Detroit and the people that we serve. I have been here now, as Loretta said, 15 years, and it has been the best place I've ever lived. I've had the privilege of living in Chicago and New York and Philadelphia and the Akron, Cleveland area, Columbus, Ohio. I've lived around in my career and certainly in my growing up years in education. And Detroit is a unique and wonderful place, and I've become a huge cheerleader of the community, and I believe so strongly in what we're trying to do here. I think there is a bright future for our community and our citizens. It's not easy. I tell people that come to work at Henry Ford, this work is not for the faint of heart. But the truth is that when you get people like we are so fortunate to have in our organization that believe so strongly in what we do, that we accomplish great things and sometimes miraculous things that really inspire others. So we're really delighted to be here. I'm also so pleased to be with Joe. We've had a partnership with the DMC for many years, and as I'll explain, there's a lot of collaboration that goes on, particularly around our community work. And we're pleased to have you, Joe, and look forward to continuing to work with you as well. As you can see, the work of our organization is very centered in the concepts of transformation, basically our community work, health and wellness, and an individual focus on each person. This vision is a relatively new vision for us. For years, our vision was to create the kind of care and comfort for our patients and their family members that we want for ourselves, and it was a very personal vision. This one is as well. This really reflects, I think, the growth of the organization over the last several years and the fact that we continue to believe that we play an important role in the community as an anchor organization, partnering with multiple kinds of organizations and individuals, as you'll see in my presentation. It all starts with our pillars, and we recently, actually in 2011, won the Malcolm Baldrige National Quality Award, and one of the aspects of that journey was creating real infrastructure around how we plan, how we think about our work, and the pillar structure has really helped motivate us to reach great heights in everything we do, but we think one of the differentiators for our organization is that community pillar. Because clearly we view it just like finance or quality and safety, we view it as very core and what we describe as load-bearing in terms of really holding up what we are really intended to do as an organization. And a very key community for us is vulnerable populations, because we recognize it's not just in Detroit, frankly, but throughout Southeast Michigan there are vulnerable populations that we are very committed to serving. In terms of, one of the important aspects of the work we do is basically to assess the needs, in terms of the community. And as you can see, the framework we use is going out, understanding community needs, an implementation plan, and then making strategic investments that really drive the work that we do. So we approach our community work not as sort of a nice thing to do or a good thing to do, but as a very strategic element of the work that we do as an organization. And you'll see, as we look at the community needs assessment, that unfortunately there are significant issues in Detroit. As Loretta mentioned, and she knows very well in her work, we are in a community that has dire needs. And as an organization, I think we have become very, very attuned to the fact that we have to play an even more substantial role in the process of trying to, reduce or eliminate racial disparities in health, to really improve the health of the community in a meaningful way. And I think, if you look at the population, just around infant mortality rate, in the United States, there are 6.1 deaths per 1,000 live births. In Michigan, that number is 7.3. In Detroit, it's 14.4, 15.9 among African American infants, and 5.6 among white infants. This is the kind of tragedy, frankly, that we live within our community. And I want to talk today specifically about how we are coming together across the community, health systems, and other partners to really try to drive change. In terms of our community health improvement work at Henry Ford, we've really focused on these strategic areas, and I'm going to talk about each of these briefly. First, wellness, which again is not typically what you see in healthcare organizations. There's a focus on illness, but we believe in the wellness aspects of what we do, and we've taken leadership in that regard. Access, equity, emerging and promising partnerships, and building an infrastructure of assessment and community benefit planning. So again, you can see the strategic elements of this. And this community pillar is led by Dr. Kimberly Dawn Wisdom, who is our Senior Vice President for Community Health and Equity and our Chief Wellness Officer, and by Barbara Rossman, who is our Chief Executive Officer at our Henry Ford Macomb Hospital. So we have really driven this through great leadership as well. In terms of wellness, this is Kimberly Dawn's work, and she has brought leaders from across our system together to focus on wellness. We've created a new center of excellence at Henry Ford around this, and as you can see, it incorporates many aspects of what we do across the organization that focuses on community, it focuses on children, it focuses on our own employees, who, by the way, in healthcare are not that healthy, and it's a kind of a problem. And also on the clinical preventive work, working with other corporations, employers in the community through our health plan, and really is aligned with the national leadership around prevention and wellness. I named Kimberly Dawn a couple years ago as our Chief Wellness Officer, and it's been a game changer for us. We're very delighted to have someone of her caliber driving these kind of changes. And in fact, she's been named to President Obama's Commission on health prevention or health promotion, disease prevention, and also equity and integration of healthcare. So it's a very important role that she plays. In addition, access to care. Again, we believe very strongly in serving our community. We take pride in our role as what is often called a safety net organization. We call it an essential organization in the community, one that we, really approach in a strategic manner. We try to work with our patients and their family members to make sure that they have the appropriate services that they need. We partner with federally qualified health centers, have for over 30 years, and work with a variety of different organizations, including faith-based, school-based, and other community partnerships. In fact, we have provided in 2012 services to 65,000 students through our school-based health clinics, both in Wayne and Macomb counties. You can see on the picture there what's called Hank. We named our mobile van Hank. We're actually getting a second one. This is with the Children's Health Project. It's a very important mobile van that provides pediatric services. We have physicians and nurses who work within this structure. It travels around, and we actually found that this really helped us in our school-based partnerships, because when the schools were moving and closing, we had already invested in school-based clinics. It got very expensive for us, so to have the ability to have these move and meet the needs where they are, I think was a real step in the right direction. Our faith-based work, I might add, is a whole variety of initiatives that we love, including what's called Called to Care, faith community nursing, screenings and health education, circles of care, faith-based kiosks in churches across Detroit, a program called Lay Aside Every Weight, Generation with Promise, ecumenical theological seminary partnerships, and Your Journey to Wellness. So we have a lot of programs that we've been partnering with churches for a number of years, and we're really proud of. In healthcare equity, one of the important aims for quality is equity, and frankly, healthcare organizations are not doing nearly enough in this space. But we actually started a campaign, a 3-year healthcare equity campaign in 2009, to do a number of things. One is to raise awareness, to implement tools to improve cross-cultural communication and collaboration, and to integrate the work that we're doing into system processes to make sure that we actually have traction around how we're providing care and make sure that we have the kind of metrics to measure our performance. You'll notice that there's a penny at the bottom here called quality and equity are two sides of the same coin. We believe that very strongly, that unless we are focusing on delivering more equity, making sure that we, in fact, are having the outcomes that demonstrate that we're not doing our job on the quality front. I would also tell you that we are convinced that it's doable. We actually had a partnership a few years ago with our health plan, Health Alliance Plan, where we eliminated disparities in breast cancer screening based on new approaches to reaching people and providing education around the importance of that screening process. We eliminated it. So we know this can work. And so we have to really approach it with a very aggressive stance. In addition, we all know that if we don't have data and we are not getting the information we need, we really can't tell if we're making a difference. So one of the campaigns that we've also had is a race, ethnicity, language data collection called RACE. And it really is about we ask because we care. Initially, there was a lot of concern if we asked people about how they identify themselves from a racial standpoint, that they would be offended. So it was very important that we shared exactly why we are doing this and the importance of getting that information so that we can provide better services to our patients. And already we have about 500,000 revised registrations in our health system, information system. So it allows us then to use that data to drive work that we do and improve the outcomes. And know, again, if we can look at outcomes, whether we're making a difference. The Healthcare Equity Campaign produced a final report. And there were a lot of accomplishments under Dr. Wisdom's leadership, including training healthcare equity ambassadors. We have 300 people in our health system who stepped up and said, we want to be champions for this work. We want to become more educated. We want to help our colleagues understand the work that we're doing. And they have also trained trainers to train others, and we've created a real system of training to help us in this area. All of our leadership academies within the health system learn about equity. So that, in fact, as leaders, we can provide the kind of leadership that's necessary to drive this agenda. And we're also providing training modules for our second-year residents. We've added an equity question to our employee engagement survey to find out if, in fact, people are seeing the work that we're doing and that it's being incorporated into their day-to-day work. And we've also done a whole online course for our Henry Ford Health System University that's been completed by about 1,300 people in our health system. So it's an ongoing effort. We have to constantly work on this, but I think we're making very good progress. One of the game-changing partnerships we've had, though, that has been particularly energizing for all of us has been the work we've done with the Detroit Medical Center, St. John Providence, and Oakwood, as well as a lot of other partners. And this has been well supported by foundations, as I'll show you in a minute. And it really was an example of how Patricia Maryland from St. John, Brian Conley, and Mike Duggan and I work together in meetings that we have routinely, coming together as CEOs of the Wayne County health systems. And we talked about the fact that, you know, the data is just horrendous around infant mortality, and why can't we do something about it? So in fact, that's what we have been working on now for a few years. And as you can see, this is basically the program of the Detroit Regional Infant Mortality Reduction Task Force. It includes these important relationships. Dr. Wisdom has provided leadership, but everyone has provided leadership because, again, everyone involved in this work has really stepped forward and believes very strongly in what we're trying to accomplish. And the funding has been significant. If you look at the funding, it's come from all of the health systems. It's come from major foundations. We've gotten $2.6 million to support this work. And I will tell you, there's a lot of scrutiny, you know, from these foundations about the discipline, the approach, making sure that we're accountable for the dollars that we've been able to secure. So it's been really a very gratifying process. We started out, this is a picture you don't see too often. Which we really liked. But it really is that notion of even competitors coming together to do work in the community is incredibly important. And this was the gathering when we met with the Robert Wood Johnson Foundation before we received the funding to go through the site visit. And I will tell you, it was a moment of great pride by all of us. I think we realized why we were in healthcare. We stepped forward with tremendous leadership. Every person contributed in a meaningful way to the success of that site visit. And I think we should all know that as a community, this is a great strength for us, because if we don't have this kind of collaboration, we're going to miss a lot of opportunities to really make a difference in improving health. Here you can see some of the kind of publicity we've received, and again, the wonderful teamwork that has taken place for this. And as you can see, again, community partners, in addition to the funding and the health systems, you can see that we are working across the community to become part of the fabric. Because, you know, working in community is not like running a health system, I will tell you. It is messy work, it requires tremendous commitment, and you have to have a willingness to give up control. Because the community, in essence, is in charge. And so we have to understand how to work in community. And we are still learning, believe me. We constantly learn every day in terms of how to connect and how to really make this successful. As you can see, the nature of what we do, again, the strategy around this work is a coordinated system of care and caring. And we've targeted specific communities within Detroit. We've built on the model of community health worker. Again, these are individuals that become trusted people in the community to help in terms of educating and working with people to get the access to care that they need, and to make sure that we are educating people constantly within our healthcare systems of how to deliver that care most effectively. We also, I might add, have a wonderful evaluator, Dr. I think it's Chota from Wayne State College of Nursing, who's serving as the evaluator for this work. So we're delighted again to have a partnership with Wayne in terms of the work that we're doing. In terms of, speaking of Wayne State Henry Ford partnerships, we have a lot of partnerships with Wayne, including obviously the medical school, nursing school, all of the schools of pharmacy and allied health. But clearly we work on issues that relate to the community activities that we're involved with. And as you can see, there are many aspects of the partnership with Wayne that we're very proud of. And actually, it's Shido. I pronounced it incorrectly. I have it on my thing here to tell me how to pronounce it, so I apologize for that. In addition, there's also been some great work with our Institute for Multicultural Health that's led by Dr. Denise White Perkins around basically the B2E, Bridges to Equity with Wayne State. And again, the opportunities to collaborate with the tremendous talent and intellectual capital that we all have to work on these issues. And Wayne has a great, great history of being very focused on the needs of our community, I think has been a great strength for us. Also, we work with GDAC in terms of the partnership with the Robert Wood Johnson Foundation on aligning forces. And this is another opportunity really to focus on reducing disparities in health, consumer engagement, quality improvement, measurement and public reporting, And I see Vern here, who really helped us start that with GDAC, and really appreciate her leadership and the opportunities to work together with that organization as well. I would add another community collaboration is the Beacon community. This is another opportunity to really drive innovation within our community around information system and improving cost, quality, and population health outcomes. So again, lots of examples of ways that we can work together. The Motion Coalition was founded in 2011. It was convened by the Detroit-Wayne County Health Authority. Again, is chaired by Dr. Kimberly Dawn Wisdom. And the mission of this is really to accelerate organizational community efforts that promote physical activity and healthy eating in children to optimize their health and well-being. And again, you can see a great collaborative effort across the organizations. Finally, I just wanted to mention a little bit about the work we've been doing with Wayne State and DMC and the City of Detroit around our Midtown Collaborative. And I think all of us know that there's a lot of opportunity to work together on the meds and eds strategy, basically bringing the strength of our anchor institutions to drive more people to live in our community, as well as to improve the services, to improve the beauty and green spaces, to improve really the life of our community and hopefully to attract more people to live here. And it's been a great success. We've done a lot of work to improve security. We partnered together with Wayne State and DMC on policing strategies. They've reduced Midtown crime by 42% since 2009. That makes it an attractive place for people to live. And already we've had 413 anchor institution employees that have participated in our Live Midtown incentives and have utilized the funds for rental, purchase, and home rehab. And it's really exciting to see, I think, how things are beginning to really change. And I would also mention that we have had Dr. Regina Benjamin, who is the U.S. Surgeon General, come in and meet with us around, again, the National Prevention Strategy and all of the initiatives that we are engaged in as a learning organization to improve health in the community. And she was very impressed and continues to partner with us around this important work. It's not easy sometimes to do this work, and I thought I'd end with a few challenges and things we might want to talk about in the Q&A. Clearly, sharing data and building trust and some of the market issues can stand in the way, but I think, as leaders, we have to rise above that and stay focused on the opportunities, which I think are considerable. And if we stay focused on the people we serve, it's much easier. Because we're all here for the same purpose. And I think that's the opportunity we have moving forward. So thank you so much, and thank you, Loretta, and look forward to the questions.
All right, thank you, Nancy. It was very exciting to hear a leader of a health system talk about such things as health equity, talking about the important work of working with communities, albeit messy, and you are right, it's kind of like watching sausage being made, but it's important work. And then also talking about that they were able to eliminate a health disparity, that being the breast cancer. So, these things work. It can happen if we continue to work it. So again, thank you, Nancy. Now it is my pleasure to introduce Joseph Mullany. Joe is the Chief Executive Officer of the Detroit Medical Center. He joined the DMC as president in April of 2012. He came to the DMC from Vanguard's health system in the New England region, where he served as president since joining Vanguard in 2005. Joe excelled at creating a culture of excellence within the New England region based upon a foundation of patient and family, safety, quality, and value creation. While under his command for 7 consecutive years, the hospitals within the New England region received numerous awards and honors. They also developed several recognized service lines, including excellence designation for stroke care, hospice care, home care, and cancer services. Join me in welcoming Joseph Mullany.
Midtown as it's coming together, and had a great walk. Also very, very honored to be here with Nancy Schlichting, who, how do you, okay, you're not hearing me in the back? Is that better? All right, sorry about that. Well, I won't repeat what I just said, but if I can give you notes later, please do. But honored to be on the same stage with Nancy, who is not only an icon here locally, but has a national reputation and has led just a wonderful organization. What struck me also, though, when I kind of was thinking about what my comments would be here today, and the beauty of going second, was to really hear how common our mission and our vision really is. Because I think a city like Detroit, or any city, will only kind of move forward where we want to be with good collaboration. Just to set the stage, I would like to talk about one of the reasons I'm here. Not only am I employed by Vanguard, but I don't think DMC, Detroit Medical Center, would be having these discussions about future long-term collaborations with the city without the support of an organization like Vanguard, who's really made us stable and grounded. And it is a company with 28 hospitals throughout 5 states. The beauty there is we do learn from other areas. We have other centers of excellence that we can import from Phoenix or San Antonio, Chicago, Boston. We can also export, which is really what we do more of. So I would say that DMC has given more to Vanguard in that regard, but Vanguard has also brought much back to us. It's a great company. It's committed to health reform. We have 3 ACOs. We're one of the original ACE demonstration projects down in San Antonio. We've got 8 bundled payment awards and the CMMI award. It's a company that really is trying to be on the leading edge, so much so that about 3 years ago, we hired Dr. Brad Perkins, who was the #2 executive at the CDC, Centers for Disease Control, to come and basically be a senior executive at a hospital or healthcare company. Said something. The difference to us was at that point, we were in our evolution. Our mission really has changed. We were a hospital company. And to kind of phrase it, in my lingo, in my life, we talk about discharging patients. People come into our door, they're here. Under current reimbursement, we always try to keep the length of stay at the appropriate level, and then we discharge them. Meaning we'll take great care of you, we offer you care and comfort, make you better, give you no harm, but then we want you out the door. What other industry does that? Could you imagine going to a Nordstrom's and as soon as you buy one thing, they just walk you out the door and say, we're going to discharge you now? No, so our evolution is really to become much more of a population health and a health company, knowing that the cares and concerns of the patient don't exit when they exit our building. And that's kind of where we've really started a lot of innovative things. Resolute Health, you talk about community. Texas, this is in Texas, outside of San Antonio. It is a community. Texas has no CON or DON laws, so you can really just build anything you want without having to go through any of that. We don't have that in most states, but in Texas they do. What we did here is very unique, is Resolute Health is a health complex that's being developed by the community. So Vanguard acquired a little over 120 acres, surveyed the community, what were your needs, what were your desires? And it wasn't to start with a hospital, it started with ambulatory, started with wellness, preventive care. They have a lot of the things like you have for the mobile pediatrics. Theirs are all run on ethylene and natural gas. They have vegetable gardens. It's things that really are what we think are going to play more to the community's needs going forward than those of us who inherit bricks and mortar. Because hospital industry previously had always been defined by bricks and mortar. I think going forward it will be defined by the community. But you can see we have many other areas which we're trying to be on the leading edge. Just kind of set base for those of you who are so close to DMC. I'm assuming everyone knows who Detroit Medical Center is. It's a combination of 8 hospitals, a little over 14,000 employees. Our payer mix is unique. It's 36% Medicaid, 33% Medicare. So roughly 70% of our business is relying on some sort of government institutional payer source, 25 commercial and self-pay. Big physician panel. We are mostly a private physician enterprise. We do have a great relationship with the Wayne State faculty. They're about a little under a third of our doctors. And you can see it's a busy, busy place. The biggest indicator there is 400,000 ER visits. When we really talk about who we need to be in collaborating with the community, I will be so happy when that number is about half of what it is today, okay? And that's our journey to get there. I can share with you some of my experience maybe in the Q&A about running a large institution in Boston that went through a version of healthcare reform in 2008. One thing that did not happen, which was billed as it was going to happen, is that ER utilization would go down. It actually went up for the 5 years post-healthcare reform. Talk about the population we serve. You can see this is compared to the national average. Our disease indicators, we have a higher incident rate, kidney disease, heart disease, COPD, heart failure, 50% higher rate nationally in the diabetic population. So we do have a very tough population to serve. I will talk to you about where we are, and this kind of measures that's everything I'm going to talk about going forward. In terms of healthy outcomes, and really the responsibility we all have to make a difference in these numbers. 500,000, or basically 65% of the Detroiters, live in a medical underserved area. 300,000, as you know, below the poverty line, 245,000 uninsured. But look how we do in terms of our health outcomes and health factors. Out of 82 counties, this county is basically 81, 82 in every indicator. A lot of work for us to do and a great challenge for us. And I'm kind of like Nancy. I've worked in Boston, Chicago. I've worked in Mississippi for 7 years, Florida, Atlanta. Run a lot of diverse systems, both community, academic, large, small. This is the best challenge I've ever had. And to be part of that and work with community leaders, I think will be something that I'm really looking forward to. DMC, who we are, what's our priority? It is the triple aim. It's really what's going to set the foundation for everything I do here in Detroit. It's about better health for the community, better healthcare quality, and at a lower cost. You know, at our commitment is to deliver value through improved quality, access, and reliability of care. We are a large employer. We have a strong history of innovation. I think one thing which Nancy talked a little bit about will be better access to technology and infrastructure as it relates to communication between providers, both public, private, community organizations. We have a wonderful system from information technology. We were a HIMSS level 6. We were there in 2006. Almost all of our order sets are now computerized, which means there's evidence-based best practice, which goes on through a computer system, which is very advanced for where we are. The problem is that system remains within the confines and walls of DMC. And many of our patients don't have their whole healthcare experience within DMC. They're either partially at Henry Ford, maybe go to St. John's, go to a nursing home, home health care. There's no connectivity or very limited connectivity about the relationship with DMC and those providers that we'd like to change. Population health, some of the things that we do, I'm proud of, but I'm also saying they're done in the wrong setting. We do, as you can see, diabetes detection in our emergency rooms. We do new pregnancy infectious disease testing and rapid HIV testing in our emergency rooms. These have been great. They've been really successful and have really helped the population here from a community health benefit standpoint. Having to do them in our ERs right now is not where we want to go going forward. We're trying to partner with community organizations and work better in that way. Talk a little bit about research, which I think is really a critical thing for Detroit. Is lucky to have many institutions here, not just the DMC, which are really committed to education and research. We currently have within our community over 1,200 clinical trials underway. It is a phenomenal thing. We educate over 1,000 residents each year. One of the things I was talking to moderator about before is unfortunately 67% of the residents stay in the state of Michigan, but that means the other 33% are leaving our state and going to work somewhere else. So we'd like to do a better job working with our community outreach partners, how to keep more of our residents within the state of Michigan. Wellness, we have 14,000 employees. We've made some decisions. I guess in a way we were talking earlier about HIV prevention and how Cuba differed from African countries. I guess the way DMC ran it, we were a little more Cuba. We decided that as far as nicotine goes, it's not going to be a democracy. It's not going to be a personal right choice. We're going to make a pledge that we will only have nicotine-free campus to start with, and now employees. Meaning any employee who is hired in the Detroit Medical Center has to sign a pledge to be nicotine-free. We also have mandatory flu shots, and those decisions often are popular. They aren't. And like Fidel Castro, I guess I'm still here today to talk about them, so I'm going to keep trying to do the things which I think make a difference in population health going forward. We have gotten a lot of, it's funny how you run a $2.5, $3 billion industry, and one of the biggest complaints I heard when I came here is we eliminated the fried chicken out of the cafeteria for employees. However, that is the reality of what we do as healthcare leaders. You hear it all, but we have gone to healthy food choices because honestly, the only way to be in healthcare and be a leader is to lead by example. And if we can't encourage wellness of our own employees, then we certainly are kind of being hypocritical when we talk about that to the community as a whole. This is just our medical staff, so you know how we're aligned. We have close to 3,000 medical staff members, largely private. We did start a PHO of 1,200 members. What I'm going to get to, where this is going to be building to, is a lot of what we have done with our accountable care organization and the partnerships we have with the community. So I will get to that. I do notice Dr. Sarniak out there. I could have talked about so much, but the time frame I was limited. I am going to focus on the adult population out here, so maybe any questions or comments we want to have, because we do have a lot of connectivity with the pediatric community, obviously with having the largest hospital in Michigan for Children's Hospital in Michigan. That is something we care. Obviously, like a lot of people here, we are proud of our quality. We have been health grades. We just had 4 leapfrog. All of our acute care hospitals just last week were given A ratings for quality and safety from Leapfrog, so that's something we're very proud of, and we, that's our focus. And the only way to get these type of awards is to focus on quality and safety. So let's talk about what happened in 2010. The healthcare spend, 31% of the GDP is projected to be taken up by healthcare costs by 2035. The trust fund would be insolvent by 2017 unless something different happened. So what happened was March 23rd, 2010, so that's the president's signature, the Affordable Care Act was signed into place. We decided, and I wasn't here at the time, but DMC decided to be part of a national pioneer organization to deal with these costs and deal with these issues and what they could do, because I think they realized a couple things. One, the care of patients is much bigger than DMC. It's a community issue, and the only way to get to that is through doing some different things. And so they became one of 32 pioneer ACOs throughout the country. I was in Boston at that time. When I left, 5 pioneer ACOs were coming out of Massachusetts. And I will say one difference between that system and here is they felt like that was sort of the tail on the end of the dog. They'd been doing care management, they'd been doing risk contracting. They, because I now refer to Boston as they, if you notice, so they had been doing all of that stuff for years and years, and felt the ACO was just adding a little bit to the way that medicine was practiced. For us at Detroit Medical Center, it was a game changer. It was our ability to really build infrastructure and change the way care is provided to the people we have. And I'll give you some stats about this. We have 224 doctors within the ACO. So just to give you the size of the population we're talking about, it's just shy of 20,000. So about 20,000 Medicare people who are in our catchment area are part of our accountable care organization. What that means in simple terms is we are responsible for those 20,000 people for the cost of their entire care that they receive, whether that be preventive care visits, home health, lengthy hospital stays, nursing home stays, care at home. Any cost that gets billed to Medicare is going to be our responsibility going forward. Talk about having a discussion that is very different than what we had a couple years ago, where again, I was worried about what happened within the walls of the hospital. As of today, every person out in the community, particularly those who fall within the 20,000 covered lives, is now my responsibility for their entire cost of their health care. So it has changed our dynamic, it's changed our relationship with community providers and with our physicians. Here's why there's a need for this area, okay? In the national average, US per patient Medicare expenditures is $12,000 a year, okay? So everybody who's Medicare, you could have a healthy 85-year-old who doesn't see anybody who's gonna have 0. You could have an extremely outlier person who's had severe medical issues in that year, be a much higher number. But on average, in the US, Medicare pays $12,000 in beneficiary cost to providers on a national average. In our Pioneer ACO, for that 20,000 people I talked to you about before, the average cost of that sample size for CMS was just shy of $19,000. So we, in this area, have a substantially higher cost curve due to a lot of the medical factors I've talked about and we'll talk about. Let's talk about the population that we take care of in this 20,000. I really didn't know what hierarchical condition categories was, and I'm still not exactly sure, but it is the way that CMS determines how healthy the population is. So as a benchmark, if the national Medicare population they deem as a 1, then anything above or below, anything below that is a healthier population. Anything above that is a much less healthier population. You can see Michigan as a whole is kind of similar to the national average. Detroit, a little bit higher. The population we serve is actually almost double what it is for Detroit. So the death rate for our seniors in Detroit is 60% higher, and our hospitalization rate is 43% higher than the rest of the state. It is a very sick population that needs involvement of everybody, from hospitals, physicians, community leaders, and community providers, if we're ever going to make a difference on some of these numbers. So as a safety net institution like Henry Ford, that's who we are. That's our mission. Our mission is we serve the underserved, education and research. So that's who we're going to be and will always be. But what we needed to do here is to have a platform to accelerate our learning, so we no longer viewed, as I've said before, our existence as a health system with 400,000 emergency room visits, who does great trauma care, takes care of the patients, and then sees them out the door. We now need to accelerate our learning to understand population health, take care of patients in ways that we've never done before, and with the relationships that we have never done before, and that's where we are. Again, there are financial incentives, just so you are aware of the whole facts. Of that $18,000 that I said was the average cost for prior years, we will go ahead at now this is where it gets tricky because you're dealing with the federal government, okay? And the data that they have is not only not as accurate as you'd like it to be, it's also not as timely as you'd like it to be. So we are in May of 2012, and I get asked the question all the time, how did you do in 2011? Because remember, we started this in 2011. I would love to tell you, but I can only tell you that we don't have all the data from the federal government to actually, with 100% certainty, say how we've done. I would say we've had enough actuaries and people look at the data that with a 98% certainty, we have lowered the cost of care pretty dramatically for those patients. And so how it works, CMS was ingenious in how they set this up. So with that 18,000 benchmark that I told you about, that is what I'm guaranteed to be paid for every patient who's now in my bucket. Any costs that go above, on average, 18,000 is going to be the responsibility of DMC. Any dollars that are cost of care is less than the $18,000 is actually going to be split. The savings will be shared. DMC will keep half of that, and half of that will go back to CMS. So it is a partnership to try to lower our care. We're very confident we're going to get there. But why I'm saying that is we've been doing this now for a year and a half, or almost, without any inkling if this will be financially beneficial for the DMC. But we know it's the right thing to do for the community, and it's led with quality. Before we even talked about the financial part, we had to change the way we did medicine in our primary care practices, okay? All these primary care practices, none of them had EMR, which is a medical record, electronic medical record. So we've gotten that in every one of those. We didn't have a disease registry, which is basically a platform saying if you come in, there's about 20 things that each doctor should be doing during your visit. How do you know the quality of that physician? If you want to find out about Henry Ford, you go online, you look at all the awards they've won, all their top ratings, all their centers of excellence. You go, tell me about Dr. Smith on the corner of Woodward and Mack. Tell me about, are they good doctors? Well, yeah, they're great doctors. How did you know? Well, my neighbor went to them about 4 months ago and had a great experience. You don't know clinically if that person who's treating you is actually clinically as good as you'd like them to be. Through a registry, we feel we can start making strides in helping educate our doctors about what makes a clinically effective office practice, and they're trying to do that. And we report those out, and behaviors are really changing at the physician level. Where we're really trying to partner with two of our partners here, DAAA and Personalized Care at Home, is that population base of patients that we have always tried to take care of as a homogeneous group really is not. That 20,000 patients is comprised of 3 different levels. A tier 1 would be a low-risk patient. That means somebody who's, a Medicare patient who's really ambulatory, healthy, walking around, can look for preventable things and some disease management, doesn't need heavy interventional care. We don't need to worry about that. You have tier 3 I'll pop up to, which is really advanced illness. That's the sickest patients with probably a 6-month expected mortality. So that's someone who's going to be passing within a certain period of time. The resources we spent on them in the past, primarily because it wasn't our sweet spot of what we did, was very inefficient. So we have partnered with Personalized Care at Home, and we pay them money to basically provide it's a beautiful thing. It's going to lower the cost of care, but it's providing a more dignified and respectful way for that person to lead the last 6 to 12 months of their life. And it really has been through a very collaborative partnership that we think we're not only improving the care, but doing it at a more effective cost standard. So, and we have many other partnerships which we will need to continue to talk about, because these are things we need to continue to focus on. Our readmission rates, which for our population are very high. That means a patient who gets readmitted back into the DMC within 30 days for a limited number of clinical indicators, COPD, CHF, AMI. We're in the mid 20 percentile, okay? It's classic being part of a system like Vanguard where you have hospitals all over the country. And we have some of the best minds, some of the really brilliant people working on our readmission issue, meaning you don't want to be coming back to the hospital less than 30 days of when you're last discharged. And we have over 20% come back. And we have the best people working on all sorts of continuum of care, transitions of care, partnerships. We looked at our numbers, and out in Phoenix, only 8% of the people who are discharged come back. So we called out to the Phoenix people, figured they'd figured something out. They had no idea. They never even looked at it. Because so much of it is beyond the control of just the hospital. It's your partnerships with your nursing homes. Are you sending them to a nursing home that's going to send the patient back within 29 days or whatever they get reimbursed for it? Is it home health care that's going to do the right thing? And so much of what we found, which is really where we're trying to make a difference in Detroit, is two things. Do the patients get their medications upon discharge, and are they the right medications? We have found that happened with very low compliance level at Detroit Medical Center. So now upon discharge, every patient, we have our own in-house pharmacy here. We're sending everyone home with their medications that were ordered by their doctor. That will make a significant difference. You also find that if a patient is discharged, the sooner they report into their PCP is almost a direct corollary to how quickly they come back. If you go see your primary care doctor less than 3 days upon being discharged, the chances of you being readmitted are very small. If it's 7 days, it's a little bit higher. After that, for each day you don't see your PCP, your chance of being readmitted goes up by 1%. So we really have had to have a partnership with our medical staff, our community doctors, to see the patients that are being discharged from our facility, many of whom have no source of payment, to try to do that. We're having to figure ways to make that partnership happen. But again, it's about the health of the community and what we have. So these are some of our challenges, but I'll get to kind of where Nancy was at the end here. Some of my key messages, I think achieving the triple aim is really going to be dependent upon effective networks. No one person can do it alone. I think the collaboration between the healthcare providers in here is more needed than ever. We need to have different type of collaborations built on long-term trust and commitments. We need to look at our employees. Again, I have a long way to go. If you come walk the walk of DMC with me like I do every day, walking the hallways, it is not the healthiest population in the world, unfortunately. It's a population that leads a hard, stressful life. You talked about how hard it is, Nancy. We use a term at our institution, which Dr. Taylor gave to me, Iris Taylor, which I love, because we're going through so much change. That's Mildred's boss over there, Dr. Taylor, so I'm talking about Iris, and Mildred's over here, but her boss is Dr. Taylor. She calls it whitewater. We're in constant whitewater. We're always changing. I've been in this role of leadership for 4.5 months, and the question I love the most I've gotten from so many employees, and even some doctors, when's the change going to stop, Joe? When's it all going to calm down? And I said, it won't. We're going to have our peaks and valleys. We'll have days where it's not quite as rocky. We'll have other times which are a little more churning than it is today. But we all got into this industry. We all got into this business for a reason. And we knew what we were getting into, and particularly in a place like Detroit. But the rewards we will see for what we can do for the community, I think, are profound. But I've got to start with my employees. So you might be hearing I have a new nickname called Fidel here pretty soon if I don't get careful and watch how I do it. But we're going to try to make those changes carefully. And we need to have a way to share data. I know there are discussions, Blue Cross Blue Shield and some others, about trying to share data, both at a state level, multi-provider level. I think that's the direction we need to go if we're really going to effectively improve care for our residents here. And like we've never done before, I will be the first to admit that it's a learning experience. The way we're providing care and the way we're going to have to go about our business when we are really a huge bricks and mortar business. DMC has about $850 million coming on board in the next 2 to 3 years of bricks and mortar construction. In an industry that I've just tried to tell you, I'm going to try to decrease my readmission rates. I'm going to try to make my employees healthier and the community healthier. It is a mindset change that we're all going through and learning from it. So we learn by working with other community partners and things like that. So that's what I had to say here today, and I appreciate you guys giving me attention.
Thank you so much, Joe. You know, I've just had the pleasure of meeting Joe when we were in the green room. I predict a bright future. You're speaking our language, partnership, collaboration. Congratulations on your nicotine-free. Now, on that fried chicken, that may get you run out of town. but we'll see what happens. All right, here comes the fun part. We get a chance to hear your questions. I'll grab this one. Thank you. So we'll get a chance to entertain some questions from the audience. Now, this first one is for both speakers, and it relates to the Affordable Care Act. The question is, what can Detroiters expect, in your opinion, with the Affordable Care Act? And how will the DMC and Henry Ford Health System help Detroiters with respect to health care reform? Nancy, why don't you start?
Sure. Well, first of all, I wish I could tell you what to expect. We are in a profound period of uncertainty in terms of healthcare reform in our state, and I would encourage everyone in this room to call your legislators and encourage them to allow the Medicaid expansion to take place, because the opportunity we have in the state, if it does, and it requires the approval of the state legislature, is to have about 500,000 people in our state have coverage that don't have it today. It's very, very important. In addition, we're hoping that we will have the exchanges in place. The federal government will step in if the state decides not to do it, and it looks like that's what's going to happen in Michigan, to again allow people that hit other income levels a little higher than the Medicaid eligibility to have discounted opportunities to get on the exchange and to purchase coverage for themselves and their family members. So I think, you know, what we hope is that we will have expansion, we will have an opportunity for the innovation that Joe described in terms of new models of care. Henry Ford also is very involved with accountable care type work. We have been forever, because we have a salaried medical group that's been at risk for capitation through our own health plan. But we also, you know, are trying to position our organization to make sure that we are helping people get access. In fact, one of our new strategies that we're working with our health plan that owns a Medicaid HMO, as well as within all of our access points on the ambulatory side and with our partnerships in the community, is how do we make sure that people get signed up? We have to work very hard on the access issue. So I think there are big opportunities. You should be looking to all of us within healthcare to really be supporting that process.
Yeah, I would agree and say that I will give my comments on the assumption that we're going to go through reform here in Michigan. I'll also tell you kind of what I experienced being in Massachusetts. I was on the Mass Hospital Association Board of Governors. I was an officer on the board, so I was part of the crafting of the law that came into effect, known there as Romney Care. I will tell you there's some interesting things that came out of that, just so you know, to level set expectations. That state, we had many differences. 93% of the population was already covered by some health plan. Education level in Massachusetts at a reading level is about the 11th grade. Here we're about the 3rd grade. So there are very vast, distinct differences in the population that are going to be changed by healthcare reform. Massachusetts, they went up to 98.9% coverage. So everybody clapped and everybody patted themselves on the back, said great job, and moved on, and did not realize the issues that were still left behind. As Nancy had mentioned, access was the primary one. Access did not really improve right away. For the first 5 years post-healthcare reform, ER utilization went up, which was really one of the things that no one predicted, and actually was one of the reasons we went into healthcare reform, because it's the white paper says, oh, now you have insurance coverage, you're going to be getting preventive care, you're going to be going to your PCP. Well, one, you need to have a PCP who's available to take patients. Two, you have to have a behavior change because people are used to their care being provided at an emergency room. That's their comfort level. They're not quite comfortable going to a PCP. So that's where a lot of the education needs to occur and take place. It did over time. It took about 5 years. After 5 years, ER utilization did go down. Preventive care did go up. The population I think we're all going to be experiencing will be interesting, though, of people who have no coverage today and are only getting episodic care for if they're sick that day, has so many underlying issues. You know, I think the diabetic population that is undiagnosed out in our communities, renal failure, things like that that really are not as well known are going to come to our forefront. And we as community providers need to be able to handle that. And I'd say the final part will be cost. Because at the end of the day, 500,000 people aren't going to get covered without some cost being put on somebody. And where that starts with the federal government, trickles down to the states, which eventually will trickle down to the providers, we need to be much more cost effective. And that's just how Massachusetts went. It started with coverage, got to 99%, went to access, we got that solved, then it's gone to cost to try to solve the cost curve. But unfortunately for people like DMC, coverage is going to be great, but what you find is there's a churn of people who are constantly going from one plan to another, bouncing around. And I know at Boston Medical Center was one of our partner hospitals in Massachusetts. Their percent of uninsured remained at 10%, even though 99% of the population was covered. 10% of the patients who they served was still uncovered because you have people constantly coming in and out of jobs, their income levels changing, they're popping from one plan to another. So I think it's going to be great. I'm fully supportive of the plan. It just is going to require a lot of work and a lot of collaboration amongst all the community providers.
Thank you. This next question is for both as well. What initiatives do you have to address mental health issues, especially relative to consumer awareness, involvement, and responsibility?
You know, we're actually very proud at Henry Ford, despite the fact over the last probably 20 years, many providers have gotten out of the mental health business. We have stayed in. We have a significant presence in the Southeast Michigan marketplace. We have a psychiatric hospital. We have focus on substance abuse and the integration of those services, a very large outpatient presence in terms of mental health services, a lot of partnerships, obviously, in the community from that perspective. And we believe that, you know, just philosophically, that we have to take the stigma away from mental health. The parity focus is very important because, as we all know, even if you look at chronic disease patients, about 25% of chronic disease patients are depressed. Huge issue in terms of the overlap of both physical health and mental health. And so we very strongly believe in that level of commitment. I will tell you that the system as it is today is not there yet in terms of really the support that's needed. I had a case in point recently with one of our employees who basically had a nervous breakdown or emotional collapse. And even our own provider in terms of long-term disability was rejecting it. I got personally involved because I think that there's often the need for an advocate, a voice. What it turned out is this employee wasn't complying with all the things that had to be in place for the coverage to continue. She obviously needed the care, but you need advocacy. And I think I talked with Senator Stabenow last week. She's working on a new initiative to really make sure that community health centers have the support that is needed. So I think we've got to find new ways of working. I happen to believe there needs to be more bridging. You know, there's discussion right now at the state level of mental health over here and physical health over here. We really need to create more integration. And I'm a big fan of that. That's counter to what some of our state people are proposing. But in the world we live in, we see the opportunity for that.
You know, I couldn't say it better. I would say that it's probably our biggest hole in terms of the healthcare map of what we have for services provided. Often services provided follow funding, and funding in behavioral health is not what it should be. I would say that our emergency rooms, I forget the exact number, so don't quote me, but such a high percent of our patients come in with co-conditions, both being medical and behavioral health. We have services to help them, but not enough. But I would say, I agree, there's something coming down called the dual eligible program, which is a program that's being looked at nationally. I know Michigan's looking to apply for that, dual eligible, which should take care of the entire healthcare needs of that dual eligible population. That's both Medicare and Medicaid. But Michigan is separating out behavioral health, and I think there are reasons why, but I would fully support trying to integrate those because, again, it's got to be a collective effort.
Okay, thank you. Nancy, this question is specifically for you, and it relates to the merger of Henry Ford and Beaumont. And the question is, what do you foresee to be the community benefits to the geographic areas that the two health systems serve?
Well, I think it's a great question. And frankly, our desire to create a partnership with Beaumont is really around how we continue to have stability, sustainability long-term in terms of healthcare needs. Henry Ford is a very interesting organization. It has, I think, an integrated model that is a great platform for health reform. But we also serve, as certainly Joe and his team do, a difficult economic population of patients. We're up to about 9% of our total revenue is uncompensated. That's tough. That's a tough place to be. And so the opportunity, frankly, to partner with a more suburban-based system that has a different payer mix is of help to us. On the flip side, they need us because we actually have a very good balance sheet that we've protected for a long time. We have relatively low debt levels. We have good cash position. We've worked very hard to achieve that over time. But I think the combination allows us more sustainability, more balance economically. And I think, you know, we will learn from each other. One of the things that's great as Joe described of being part of a national system, the same is true when you partner with anyone and bring an organization together, is you learn a lot from the experience. And even in the due diligence period that we've been going through, you know, you put a mirror in front of yourself and you learn a lot in terms of how you can get better, stronger, improve. And I think all of those are things that are good for our community. You know, the next few years are going to be very tough sledding in healthcare. They've been tough the last couple of years with some of the Medicare cuts that we've experienced. The deficit reduction is out there. Healthcare is a target. And we're very concerned about the additional cuts we might see on all levels of payment, whether it's disproportionate share payment, which is basically helping safety net organizations. It's academic payment that is helping teaching, you know, providing teaching for doctors and other caregivers. All of these things are under threat right now. And so we are very concerned about how we can, you know, get stronger, improve our performance, and we think the partnership will allow us to do that even at a higher rate.
Fantastic. I've been given the sign that I can only ask one more question, and there's lots of great questions up here. So I'm going to cheat a little bit. First, I'm going to make the one question one that both of you can answer, and then I'm going to try to squeeze two thoughts into one. So the question relates to community health workers and how health systems might bridge strategies so that you can use community health workers for behavior change, specifically around chronic disease management. But then also if you can speak a little bit to the issue of health literacy and how that. Joe, why don't you go ahead and start?
Well, I was hoping of the other questions you asked, I had no problem going first. This one will be harder for me because I'm really not up to
Nancy, you wanna
speed on
go?
that one.
Yeah, well, I'll be happy to talk a little bit because as Joe was describing accountable care models where you assume the responsibility for the care of a population. As I mentioned, we've been doing that a long time at Henry Ford because we own a health plan. And so we have the risk for the population of patients that we serve. And also we've done it with our PACE program, which is the Center for Senior Independence. It's a capitated model where you take responsibility for a pretty good size group of Medicare patients and try to basically keep them out of nursing homes. So you do a lot of things with adult daycare, home support, all types of services that really are very value added from a patient and family perspective. But one of the things we've learned in that process is that we tend to pile on pretty high cost care. We have doctors and nurses, pharmacists, high cost, and often they cannot influence the behavior change that's really needed. And the community health worker has been a tremendous asset, with our work with infant mortality, but I think it has much broader application. That's why when we work in churches and we work in schools, we find that, responsible leaders have a great influence, whether it's over a congregation or it's in a school where you have a nurse there. In the areas, for example, where we have school-based clinics, we have almost zero pregnancy rates. We have completely 100% immunization rates. When you have a responsible person there that can interact with the teachers or interact with the congregation in a church, it changes the dynamic. So I think we've got to think about much more creative solutions around how we change behavior, which is the hardest thing to do in healthcare, by the way. The fried chicken may go, but that doesn't mean people aren't eating fried chicken. It's really tough. So I think we all are influenced by our peers, we're influenced by the people we respect, and I think there's a big role there that can be played.
Absolutely. There is one quick question that staff can probably answer, and it's about the presentation slides. Are they going to be made available, and how will they be made available? The answer is yes, they will be made available, and they'll be on a website of some sort. You want to? Sure. Yep. And actually, you might want to, you're going to be giving the closing remarks?
Yep.
Okay, so I think, did anyone want to speak to health literacy at all quickly?
Oh, yeah, I will talk about health literacy quickly. Again, one of the things, our equity campaign has revealed, and also our readmission work has revealed to us, is that, we think that health literacy is all about people that can't read or can't understand. I will tell you that health literacy is universal. We have a huge problem in how we communicate with people in healthcare, and when we communicate, and what we communicate, and the follow-up and the support that's needed. My dad's a nuclear engineer, and he's 90 years old, and I'm in charge of his health care. And he was in the hospital last year, Henry Ford. Fortunately, he goes home, and he's sitting there trying to figure out his new meds. And he has Ziploc bags, for different times of days, trying to figure it out. And, obviously, I was helpful to him in that process, I hope. But, people need a lot of support to really manage their health. And we have not yet figured it out. So health literacy is universal in my view. We can say it's about socioeconomic status, but I think it's about fear, and it's about understanding, it's about the language we use, and I think we've got a lot of work to do.
Absolutely. Well, my closing remarks, thank you for the opportunity to be your moderator today, and let's give both of our speakers a round.
Let's have another round of applause for Loretta for moderating for us today as well. Thank you very much. And again, thank you so much, Nancy and Joe. That was fantastic information. I learned a great deal. I hope you did as well. And again, we thank you for coming today. Before you leave, we have a couple of gifts we'd like to give to our presenters today. If you'd like to join me up here, please. Nancy, as you were mentioning earlier, you were gracious enough to come in the past and be part of ALGIP and speak with your expertise and knowledge about various topics. And with that said, you already have a copy of Race and Remembrance, which is Arthur L. Johnson's memoir. So we'd like to present to you today A Revolution, Strategies for Urban Reinvention of Detroit.
Great.
From Wayne State University Press.
Thank you so much.
Again for
Appreciate it so
participating.
much. Thank you.
Joe, we'd like to thank you as well for your time today and your expertise in this very, very interesting and important topic. And we would again like to present you with a copy of Race and Remembrance, a memoir of Arthur L. Johnson. Thank you. We also have a copy of Race and Remembrance for you. Thank you again for your time today. We appreciate that very much.
Thank you so much.
Thank you, Joe.
Again, we thank you all so much for coming again, to our sponsors for making this possible. Again, to Shekinah for being with us today as well. If you have a chance to, before you leave, please check out our newly renovated McGregor reflecting ponds just to the south of our building. We dedicated them a couple of weeks ago. They are gorgeous. Please check them out. And again, we mentioned the University Press and the publications of our gifts today. If you're not busy, next Saturday evening, May 18th, we're putting on an event in Grand Rapids at the Public Museum to celebrate the Michigan Writers Series from 6:30 to 8 over there. Please join us if you'd like. You can RSVP through our events calendar at alumni.wayne.edu. And as Loretta mentioned, if you'd like a copy of the presentations today, or to access the video that we've shot of the lecture series today, we will make that available at the newly renovated and improved alumni.wayne.edu website as well. So thank you again for coming, and have a wonderful day.